Dr. Alaa Abdelgalil is going to present the last talk in this session entitled Imaging of Cranial Nerves 9 and 12.
So now we're talking about lower cranial nerves. What could possibly go wrong? Overview of the lecture, we'll start with a bit of anatomy of these four nerves. After that, we'll go through pathologies that we can see on our scans, and we'll finish off by a summary. To be able to understand the anatomy of these four nerves, we need to understand the anatomy of two skull-base foramina. The first one is the jugular foramen. So this is quite a big foramen. It's actually the second biggest foramen in the skull base after the foramen magnum. And it is divided into two different components by what we call the jugular spine. It divides it into a slightly bigger component posterolaterally, and this is what we call the pars vascularis, and a smaller compartment anteromedially, which is the pars nervosa. The structures passing through the vascularis are the jugular bulbs, of course, I'm sure we all know about it, and two nerves, which are number 10, which is the vagus, and number 11, the spinal accessory nerve. The pars nervosa has only two structures, so the inferior pectoral sinus, this is the vessel, and cranial nerve number 9, the glossopharyngeal nerve. So for some odd reason, the pars nervosa has actually less nerves than the pars vascularis, just to confuse everyone. These skull-base foramina, the jugular foramina, are very rarely symmetrical, and this sometimes can cause problems in our MR, but of course on CT it's very easy to make a diagnosis of just an asymmetrical jugular foramen. It's easily identifiable on our CT and MRI scans, so this is an example here just to show you the jugular spine, which divides the foramen into the pars vascularis posteriorly and slightly laterally, and the pars nervosa is anteriorly and medially. On the MR, again, the same jugular spine here, and you can see the pars nervosa and the pars vascularis. The second canal is the hypoglossal canal, and as the name implies, only one nerve passes through it, which is the hypoglossal nerve. It lies at a slightly lower level than the jugular foramen in the base of the clivus, and through it will pass only the hypoglossal nerve, which is surrounded by the venous plexus. And this venous plexus, actually, when we give GAD, it will help you identify, see the nerve itself passing through the canal. On CT, it should be bilateral symmetrical. If you see asymmetry here, think of something going on, like a destructive lesion, like maybe a schwannoma or something like that. So this is the canal on your CT, and on MR, you can actually see the nerve sometimes without even GAD. Can you see the nerve passing through it now? Let's just concentrate now on number 9. This is the first nerve in this lecture, which is the glossopharyngeal nerve. So we have 4 nuclei at the junction between the medulla and pons, and from there the nerve arises into the basal cisterns. And as it does so, it passes through an important structure, Richard has mentioned briefly, which is the cerebellar flocculus. And this is actually one of the clues that we use to identify the nerve. So the only structure passing through the substance of the cerebellar flocculus is going to be your number 9. And another clue to help us identify these nerves on our scan is that it lies directly below number 8. Of course, all of us will know how to search for number 8. And directly above number 10, which is actually about maybe double the size. So number 9 is much thinner than number 10, which is your vagus. And after that, the nerve exits the cranial cavity through the pars nervosa alongside with the inferior pectoral sinus. The functions of cranial nerve number 9, the glossopharyngeal, so it has sensory function, posterior third of the tongue, palatine tonsils, pharynx, and middle ear. Special sensory, taste from the posterior third of the tongue, and motor function innervating the stylopharyngeus, yes, and the superior constrictor muscle. When anything goes wrong here because of the motor function, these patients will present with dysphagia because usually the superior constrictor muscle will not be functioning properly. Vagus is your longest cranial nerve, and it arises from the medulla oblongata, 4 nuclei on each side, and it exits into the basal cisterns directly below the flocculus. So the nerve directly below the cerebellar flocculus is going to be your number 10, and it's directly also below number 9 and above number 11. These are the clues that we will use in a moment to show you the nerves, the normal nerves in our scan. And after that, it exits the skull base or the cranial cavity through the pars vascularis alongside with the jugular bulb and number 11. It's quite a complex nerve, has many functions: general sensory function, visceral sensory function, special sensory function, branchial motor function to the muscles, and also the visceral motor function, which innervates the viscera, including the smooth muscles and glands. And one of the nerves which arise from the vagus is your recurrent laryngeal. And that's why if anything goes wrong, these patients will usually present with vocal cord palsy on the same side. Cranial nerve number 11, the spinal accessory nerve, it's a complex nerve. It has two different parts. So we have the smaller cranial compartment, or the smaller cranial part of the nerve, and the spinal part of the nerve. So the smaller part arises from the medulla oblongata. It intercommunicates with cranial nerve number 10 and also the spinal segment of number 11, and it passes through the pars vascularis alongside the spinal part as well. It supplies only two muscles, so it has no sensory functions whatsoever. So these are the uvula and the levator villi palatini muscles. The spinal compartment, as we said, this is the slightly biggest part of the nerve, and it arises from from C1 to 5 ventral horns, and after that, the fibers passes upwards through the spaces between the nerves, and after that it enters through the foramen magnum to join the cranial compartment before it exits the skull base through the jugular foramen. How can we identify it? It's directly below cranial nerve number 10 before it exits through the pars vascularis, as you can see here. As we said, cranial nerve number 11 is a purely motor nerve. It supplies only 4 muscles. So the cranial component supplies the uvula and the levator villi palatini, and the spinal component supplies the sternomastoid and the trapezius. And that's why these patients, when we have a patient with cranial nerve number 11 palsy, they will present with what? With weak shoulder elevation. The last nerve is number 12, the hypoglossal nerve, and it arises from multiple nuclei in the lower part of the medulla oblongata. And it enters the basal cisterns. It passes through the space between two important arteries, which is the pica and the vertebral artery. So the posterior inferior cerebellar artery and the vertebral artery. And that's a clue actually for us to look for the nerve before it reaches the hypoglossal canal. And after that, it will exit through the hypoglossal foramen alongside the surrounding venous plexus. It is a purely motor nerve. It supplies all of the intrinsic tongue muscles. The extrinsic tongue muscle, 3 out of 4, which are the genioglossus, hyoglossus, styloglossus, and also the geniohyoid muscle. If anything goes wrong, the clue on your image, on your CT or MRI, will be hemiatrophy in the tongue because it supplies the ipsilateral intrinsic tongue muscle. So you'll find a sharply demarcated border between the atrophic side, the symptomatic side, and the normal side. After that, where do these nerves go after they exit the cranial cavities? All of them will enter this one space. And this is our carotid space. And it's very important to know the distribution of these nerves inside the space. We'll go through them one by one. So cranial number 9 is the most anterior structure, which means that if we are dealing with a schwannoma or a nerve sheath tumor in number 9, it will push both vessels in the space posteriorly. So the carotid and the jug will be pushed posteriorly. The posterior-most nerves are number 10 and 11. So any mass there, this means that the carotid will be pushed anteriorly and the jug will be pushed laterally. Number 12 is the most medial structure, which means that if we have a mass lesion here in number 12, it will push both vessels laterally. So these are the clues that we need to know about. Very important to know that we have a very important neighbor next to us, which is the retropharyngeal space there. And sometimes you can get metastatic RP nodes, retropharyngeal nodes. And in some patients, the fascia, medial fascia of the space is deficient, which means that if this RP node starts causing problems, the closest nerve to it will be number 12. And we'll show you a few examples here. At the level of the hyoid, just above the level of the hyoid, 3 out of the 4 nerves will leave the carotid space. So these are number 9, 11, and 12. Only cranial nerve number 10 will continue below the level of the hyoid, which is, again, an important clue. If you have a nerve sheath tumor below the hyoid, it's not going to be number 9, not number 11, not number 12. It will going to be a vagus nerve sheath tumor. How can we identify these nerves on your scans? Now we know the clues. This is the cerebellar flocculus. So this nerve must be number 9. It's embedded within the substance of the nerve, of the flocculus, and after that it exits through the pars nervosa. Can you see how thicker the cranial number 10 is compared to 9? And it lies below the flocculus. This is just the lower end of the flocculus here. And it exits through the pars vascularis of your jugular foramen. This is at the level of the foramen magnum. You can see that there are two dots. This is the cranial number 11 going up. This is the spinal component going up. And after that, can you see the fibers here? Going up through the foramen magnum before it joins the cranial part of the nerve. And that's your two nerves here, so the spinal and the cranial. And after that, both of them will exit through the pars vascularis. In my practice, the easiest way to identify them is the sagittal plane. Actually, you'll be able to easily identify these two important nerves. All of us know them, number 7 and 8. Okay, these are easily identifiable. They exit through the IAC. The nerve directly below us is going to be number 9. And this exits through the pars nervosa. Directly below 9 is going to be number 10, slightly thicker than number 9. And below number 10 is going to be your 11, and both of them will exit through the pars vascularis. If you go lower down to be able to see number 12, that's your hypoglossal gland, and these are the nerves. Can you see these two vessels? So these are the pica, or the pica, and the vertebral arteries. So the only structure, the only nervous structure which passes through this gap is going to be your number 12. And with the post-contrast sequence, this is an MP-RAGE post-GAD. You can see the nerves passing and the venous plexus surrounding both nerves. So what could possibly go wrong? We'll go through a few cases here. Patient with right-sided pulsatile tinnitus. What is wrong here? So if you just compare the jugular foramina on both sides, on the left-hand side, this is completely normal. You can see the signal void on this T2-weighted axial image. But on the right-hand side, there's a mass lesion occupying the foramen. And this is bright on T2, and you can see the vascular channels, the small arterial branches or vascular branches running through it. This is what we call the salt and pepper appearance. So this is the classical appearance of a glomus jugulare. So it starts usually at the lateral part of the jugular foramen, and after that it starts going more medially and destroys the whole petrous bone. On T1WI, it's typically low signal intensity, and still you can see the vascular channels inside the tumor. And if you give GAD, it's very, very shiny, very bright. So these are all the typical findings or appearances of the glomus. If you can remember, we mentioned something about if you find one of these paragangliomas, you need to do what? Look for more. Look for more. Okay, so this is a case of hereditary paragangliomatosis, bilateral neck lumps. And these are very intensely enhancing mass lesions. And this is the level of the hyoid, which means that this mass is actually going slightly above and slightly below the level of the hyoid, which means that which cranial nerve here is involved. It has to be a vagus. It has to be the vagus. So this is the glomus vagale. And as we all agreed now, you need to look for more, and we actually have glomus jugulatum panicum. So this is a case of hereditary paragangliomatosis. Another patient with left neck lump. So this is not a paraganglioma. Why? Because it's not intensely enhancing on CT. MRI sometimes can be very confusing because you may not be able to appreciate the differentiation between the level of enhancement. But I find that usually CT is easier to help you say that this is actually a nerve sheath tumor or a paraganglioma. And let's try and find out which nerve here this nerve sheath tumor is arising from. The carotids are pushed anteriorly. The jug is pushed laterally. So this has to be a structure or a nerve which is in the posterior aspect of the space. So it has to be number 10 or 11 schwannoma. On T2WI, heterogeneous high T2 signal and enhancing on the post-contrast. So this was a vagal schwannoma. This is an interesting case. So forgot wife's birthday, unexplained new left vocal cord palsy soon after. Well, some mistakes in life can lead to serious consequences and leave deep scars. I'm not talking about emotional scars here, I'm talking about physical scars. So I'm just talking to my fellow men, don't learn the lesson the hard way. So what's wrong here? What happened to this poor chap? So we can see a fracture through the skull base going into which part of the jugular foramen? This is the vascularis, right? So two nerves passes here, number 10 and 11. And one of the branches of number 10 is recurrent laryngeal. That's why this patient was actually presenting with vocal cord palsy. Another patient with right earache, right neck lump, and hoarseness of voice. And here you can see the signs of vocal cord palsy. So these are secondary signs. So it's way beyond the scope of this lecture. Just briefly, we have this is what we call the Sale sign, dilatation in the piriform fossa as well. So these are all signs of vocal cord palsy on the right-hand side. So what's the cause of that? If you see signs of one of these nerves palsies, you need to check the whole area, so from the brainstem all the way down till the end of the nerve. And here you can see that the problem was actually in the retropharyngeal space. We have a malignant RP node invading the space, pushing the carotid anteriorly. So this means that the posterior structures in the space have been invaded, number 10 and 11. And the primary was actually in the floor of the mouth, so this is a metastatic RP node. And this is something that we see very often actually in post-operative cases. Patient with previous left neck dissection, swelling left lower neck. You can just compare the sternemastoids on both sides. So the left side is way thinner than the right side. And if you look at the trapezius as well, the left trapezius is now completely fatty, right? So this means that we have actually palsy in number 11. And in many occasions, you will need to sacrifice number 11 during the surgery in radical neck dissection. And after a while, these patients may have what we call a pseudo-lesion because one of the muscles takes over the elevation of the shoulder. And this is the levatoscapular muscle. These patients can present with a pseudomass or a lump on the same side. And you can see here the difference between the levatoscapulae on both sides. So this is actually not a mass. Don't biopsy it. It's normal. So this was just a pseudo-lesion. Patient with melanoma behind left ear, abnormal tongue examination, and you can see here on this post-contrast CT of the oral cavity that the left hemitongue is atrophic, completely fatty, with the sharply demarcated medial margin. So this means that we have hypoglossal nerve palsy. But why is that? You need to check the whole area from the brainstem till the level of the hyoid. And that's the problem here. The RP node going into the carotid space causing nerve number 12 palsy. We said that this is the closest nerve to any RP node. Another example, patient with headache, abnormal movement of the tongue, and this is a T1 WI of the suprahyoid neck and the oral cavity. So what's wrong here? This is a T1. So the bright on T1 is going to be fat. So we have fatty atrophy of the tongue on the left side and sharply demarcated medial border. Look at the foramina. Which foramina is that? This is the hypoglossal canal. And we have expansion rather than destruction, so we're dealing with something likely to be benign rather than malignant destructive lesion on the symptomatic side. On MR, this is a partly cystic lesion in the medial aspect of the space, the carotid space. Can you see that the vessels are pushed laterally, which confirms that this is of hypoglossal origin. And on the T2 sagittal, you can see that this lesion is following the path of the nerve through the hypoglossal foramen, so this was an enhancing schwannoma. Patient with partial right hypoglossal nerve palsy, and here again the same thing on the T1 WI sequence, fatty atrophy in the tongue, but actually we didn't find anything wrong with the nerve, so this is what sometimes we can see in idiopathic hypoglossal nerve palsy, but this is a very dangerous diagnosis to make. You need to do everything you can. CT and MRI before you call it idiopathic. There may be a small lesion causing the palsy, and you may actually, this will make a huge difference in the patient's management. Patient with dysphagia, and this is the Fiesta sequence. You can see a mass lesion just below the CPA on the right side, and on the sagittal you can see actually the two nerves. So these are the occlus, cranial number 7, the facial, and the vestibulocochlear, and this lesion is just below it, which means that we're dealing with a nerve tumor coming from number 9. This lesion is T1 low signal, post-contrast, intense enhancement with central necrosis or central cystic component. These are typical signs of a schwannoma. Another patient with melanoma, headache. So this is which nerve? This is number 9. Why? Because it's going to which part of the foramen? Is the pars nervosa, the anterior medial part of the canal. And this is the ovascularis here, right? So this is actually a metastasis, melanoma metastasis in cranial number 9. And we also have metastases elsewhere in number 10 on the contralateral side. This is sometimes we see, it's rare, but we do see them in patients with chiari malformations. So patient with unsteadiness, frequent collapses, intermittent hoarse voice, bilateral vocal cord paresis, and here you can see the tonsillar herniation, you can see a big syrinx, and on the MRC spine you can see how big this syrinx is. So what's the idea? Why do these patients present with lower cranial nerve palsies? Actually because of the drag effect of the spinal cord. When it herniates downwards, it drags with it the medulla oblongata, and this means that the lower cranial nerves can be palsied, can be affected by that. So take-home message, the lower cranial nerves exit the skull through the jugular and hypoglossal foramina. You know how to look for each nerve now, and don't forget to check the brainstem. The pathology may be there rather than the nerve itself. And more importantly, don't forget your wife's birthday. By this, I'd like to finish, and thank you for your attention.